of that I have. Yeah.
And then I'll just quickly go through it and refer to
Right. Okay, I think in the interest of time, we should get 2:59. I would just bring it. There's nothing. So, maybe I'll give people 1 minute. I don't want to run out of time at the end. This is good. Hi, everyone. Hello, everyone, and welcome to our global symposium on the renaissance and promise of psychedelics for mental and substance use disorder treatment. Thank you all for joining us here today. For those of you who attended the discussion session last night, I see this as a continuation of the conversation that we started last night, but today we'll have PowerPoint slides. My name is Dr. JohannesThrul. I'm an associate professor in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health, and I'll be the chair of today's session. With me on stage today are my colleagues Dr. Margit Petersen from Aarhus University and Dr. David Erritzoe from Imperial College London. We were supposed to have additional speakers, but my colleagues Dr. David and Mary Yaden from Johns Hopkins were unable to be here and present in person today. They sent their regards and are very sorry that they won't be able to be here. So here's the run of show. I will give the first presentation on behalf of my colleagues, David and Mary. Then we will hear the presentation of Dr. Petersen and Dr. Erritzoe in that order. And after that, I will put on my discussant hat and reflect on some of the content that we heard today. And finally, we will have time for questions from the audience. With that in mind, I would like to reserve questions on the individual talk to the end. So with that, I'm going to get started with the first presentation. As you all know, giving a talk of a colleague is quite of a challenge. And I certainly feel that, and I will try very hard to do it justice. Perfect. So Doctors David and Mary Yaden send their regards and are sorry that they cannot be here with us today to give this presentation. They are both affiliated with the Center for Psychedelic and Consciousness Research at Johns Hopkins and have no financial disclosures, but the presentation may be biased towards research happening at the center at Johns Hopkins. So today we will be focusing on psychedelics, and more specifically on psilocybin. I'll start with a brief history of psychedelic research. So we know from anthropological and archaeochemistry research that there is some evidence that psilocybin and other psychedelics have been used for at least hundreds and perhaps thousands of years. There's evidence of use in several places around the world, but most of the evidence is from Central America. The Swiss chemist Albert Hofmann synthesized LSD in 1938, and later isolated psilocybin in psychedelic mushrooms from Mexico. And there are hundreds of studies in psychedelics in the 1950s and 60s, but the Controlled Substances Act of 1971 stopped almost all research in this area. What we're currently in is what we hear the so-called psychedelic renaissance, with many studies coming out and research centers opening around the world. In the US, the Food and Drug Administration, the FDA, has granted psilocybin the breakthrough therapy designation, which will allow it to move more quickly through the review process for treatment-resistant depression to begin with. So a brief background on the pharmacology. Psilocin, here on the right-hand side, is the active metabolite of psilocybin, and it resembles the serotonin molecule. The classic psychedelics are substances that exert their effect primarily by an agonist action on brain serotonin 5-HT2A receptors. Classic psychedelics affect cortical neurons by increasing neuronal growth and dendritic branching. And here you can see for dendritic branching from psychedelics are increased compared to vehicle control. And each of these are 5-HT2A agonists, so we would expect to see the same for psilocybin. As far as preclinical effects are concerned, there's a lot of research on animal models, on rodents, and I just want to bring one example study that examined the effects of psilocybin on rodents using a depression behavioral assay. In this depression assay, which is called the forced swim test, climbing or swimming are seen as non-depressive behaviors, and immobility is seen as depressive behavior. Note the air quotes around depressive behaviors because there is some controversy around how well this assay models depression in humans. So the results of this study, this is after 7 days after administration. Here on the x-axis you see different types of behaviors. On the y-axis you see how much time these animals are spending engaging in the respective behavior. And the administration here was saline control, ketamine, and psilocybin. And what you can see here, after 7 days, the immobile behavior was reduced for both ketamine and psilocybin compared to control, and swimming was increased. After 35 days, psilocybin still has an antidepressant effect. Emerging findings are complicated, and more research is needed to confirm if these results really hold up. But you can see that psilocybin has an effect at 35 days, whereas ketamine does not. So some research on the physiological effects. Physiologically, psilocybin increases transient heart rate and blood pressure. It can result in mild headaches, but generally it's non-toxic, so the LD50 in rodents is extremely high, and there are almost no fatal overdoses ever confirmed in humans. Psychedelics are not reinforcing in animal models, and addiction is quite rare in humans. As far as neuroimaging results are concerned, there's been a great deal of media attention on resting state functional connectivity. So there appears to be a replicated finding of greater resting state functional connectivity, and widely reported findings related to the default mode network and its role in effects of psychedelics, but these effects are not particularly specific, so the default mode network is inhibited in most psychoactive drugs, so it's not unique to psychedelics and maybe not a major therapeutic mechanism. Set and setting are really important for psychedelics, so I want to spend some time to talk about that. Set and setting is a phrase created by psychedelics researchers in the 1960s, and that has stuck. Set is the mindset, which we refer to as expectations, cultural messages, or clinical messages, whereas setting is the context in which the use happens. So it's the physical location, can be the treatment room, or the social situation. Set and setting are important to consider both for recreational use, but also for administration in treatment settings. So this is an example of data on recreational use. This was a survey done with almost 2,000 respondents who were asked to report challenging experiences with psychedelics. And of these respondents, 39% rated the experience as among the top 5 most challenging experiences of their lifetime. 11% reported putting themselves or others at risk of physical harm, and 2.7% reported getting medical help during the occasion. So these 11% putting self or others at risk of harm is a sobering statistic. However, when we compare the harm of psychedelics to other substances, and this is a study conducted by David Nutt from the UK, we see that LSD here and mushrooms are at the very low end of the spectrum with particularly like no harm to others. So we know they're relatively safe. In recreational use settings, there is also some evidence here from epidemiological research that there may be even a protective effect from psychedelics when used in recreational settings, here on lifetime psychedelic use for previous year's suicide attempt. So when we look at clinical research, at Johns Hopkins, most of the clinical research happens at the Behavioral Pharmacology Research Unit, and that's where the psychedelic sessions are conducted. So a typical procedure in a trial looks like this, where there are a bunch of processes in place to reduce the risk for participants. So at first, screening occurs to remove participants with cardiac issues or personal family history of psychotic disorders. There are preparation sessions before the first administration that provide psychoeducation and what to expect and build rapport with the session guides. Integration sessions happen after the administration to allow participants to discuss and process their experience. This here is an example of a session itself where 2 guides are present. The sessions are audio and video recorded. Participants lie down with eye shades and headphones, and participants can ask for therapeutic touch, which is a handhold and is being modeled here on the picture. But even though all of these safety measures are in place, these experiences are challenging. Many participants endorse that the experience during the session is challenging. And here is an exemplary quote of a participant who says, "It is not fun, that's the thing. It is a hard experience. It is a very rich experience. You know a lot of things to learn from it, but how much fun is learning, you know?" So a little bit more about the subjective effects during these sessions. This is a slide here that has 2 panels. The top panel is on overall drug effect. The bottom panel is on joy and intense happiness. Here on the x-axis, you have time in minutes. So this goes out to 6 hours. And then on the y-axis, you have the intensity of the effect. And so you can see quite robust effect over about 5 to 6 hours. Some of the effects that we focus on a lot are these mystical type experiences. So one way of understanding some of the more therapeutic experiences is what we would call a mystical type experience. This term comes from William James, who used the term to refer to feelings of connectedness, not really anti-rationalism or supernaturalism, what we might expect. There's a new book out from Dr. David Yaden describing James's foundational work and reviewing recent relevant research, if you're interested in that. So what does mystical experience mean? We usually assess this with the mystical experience questionnaire, and it contains 4 factors. The first factor is mystical, which refers to internal unity, experiences of pure being and pure awareness beyond the world of sense impressions. Factor 2 is positive mood, an experience of amazement. Factor 3 is transcendent of time and space, the loss of your usual sense of time and space. And factor 4 is ineffability, the sense that the experience cannot be described adequately in words. And here's an exemplary quote of a participant. I experienced a feeling of no boundaries, where I didn't know where I ended and where my surroundings began. Somehow I was able to comprehend what oneness is. These experiences matter for the treatment effects. So here are a few panels that look at correlations between the intensity of mystical experiences on session days with later therapeutic outcomes. So you can see for all of these a robust correlation between The mystical experience, the greater the mystical experience, the greater the change towards beneficial effects. So on the left-hand side, you have smoking cravings for a smoking cessation intervention. In the middle, there's a depression change score, and on the right-hand side, an anxiety change score. So we know that the degree to which participants endorse this measure acutely correlates with outcomes weeks or months later. So let me go into some of the treatment efficacy results on substance use disorders. First, I want to talk about tobacco use or nicotine use disorder, smoking cessation studies. The first study done at Hopkins was an open label trial with 15 participants. Those participants received 2 doses of psilocybin paired with a 15-week smoking cessation program. And outcomes included an open label, single arm. 12 of 15 participants, so 80%, showed biologically confirmed abstinence at 6 months, so breath, carbon monoxide confirmed. It's important to sort of put this into perspective. In the best evidence smoking cessation treatments we have, where we usually combine medication with behavioral treatments, we get to about 35% efficacy. But I think even more interestingly, in this study, the authors in follow-up studies conducted longer-term follow-up with participants, and on average, at 30-month follow-up, 9 patients, so 60%, were still confirmed abstinent. For smoking cessation, there are a couple of ongoing trials at Johns Hopkins. So one that is a randomized trial that uses nicotine replacement, nicotine patch more specifically as control, is pretty much done recruiting now. And another study that is just getting off the ground, which is a multi-site study between Hopkins, University of Alabama, and NYU, that uses an inactive placebo. And this study is important to mention because it is relevant as the first psychedelic-assisted treatment study funded by the U.S. National Institute on Drug Abuse of the NIH since this new phase of the renaissance of psychedelic research. So it's the first NIH-funded study on this in 50 years. So for alcohol use disorder, there was just a study published in JAMA a few months ago that was already discussed to some extent last night, which was a randomized controlled trial with an inactive placebo, diphenhydramine, Benadryl, antihistamine, that delivered 2 doses of psilocybin and paired with a 12-week manualized psychotherapy. What this study found was a reduction in heavy drinking days, significantly more reduction in the psilocybin group compared to the inactive placebo. And mean daily alcohol drinks were also lower in the psilocybin group. For alcohol use disorder, there are a few ongoing trials at University of Zurich and one at Johns Hopkins that looks at psilocybin treatment for major depression with co-occurring alcohol use disorder. And another couple of studies, one at Copenhagen University for alcohol use disorder and at University of Iowa. For opioid use disorder, which is, as you all know, a big issue in the US right now, there are 2 ongoing trials, one on adjunctive effects of psilocybin and buprenorphine at University of Wisconsin, and then another study with individuals who are actively engaged in methadone maintenance treatment, but still are using illicit opioids outside of their agonist treatment. And there's one trial ongoing at University of Alabama on cocaine use disorder and psilocybin. So let's look at some future directions for psychedelics and substance use disorder treatment. We've covered some data showing evidence for potential efficacy of psilocybin in all of these areas. So if psilocybin were approved, how might it be integrated into current substance use disorder treatments? So this is based on a study that Dr. Yaden published in 2021, in particularly focusing on 12-step programs. So some 12-step programs are already incorporating psychedelics in an underground manner. There is substantial hope that 12-step programs will not be against psychedelic forms of treatment, despite the typical prohibition against opioid agonist treatment, for example. The founder of AA and 12-step programs, Bill Wilson, had the first spiritual experience that led to his sobriety while under the influence of scopolamine, which is belladonna, which is often considered a hallucinogen. Wilson also later took LSD under the care of a psychiatrist and advocated for the use. However, the board of AA actively suppressed Wilson's comments on the topic. But there is some hope that psychedelics could be easily integrated into 12-step programs as well as rehab settings. Psychedelics such as psilocybin could also complement existing evidence-based treatments and psychotherapies. So most forms of medication-assisted treatment could include a psychedelic session at either the initiation of treatment or as a way to maintain motivation throughout treatment. Similarly, psychosocial treatments such as CBT, contingency management, or motivational interviewing could include a psychedelic session as part of the overall treatment package. And psychedelics could, in this way, complement, but don't need to replace existing evidence-based forms of substance use disorder treatment. So, will psychedelics become a mainstream substance use disorder treatment? That is unclear. But it looks like psilocybin will likely be approved by the FDA for mood disorders, so it seems likely that it may eventually also be approved or at least used for substance use disorders, at least based on the available data to date. While this is an exciting prospect, as a new tool for substance use disorder treatment would be desperately needed by many patients and providers, there are also some reasons for concern. These treatments certainly don't work for everyone. Adverse effects occur. More research is needed before firm inferences can be drawn, and the risk-benefit ratio must be more precisely quantified. These two pieces here referenced on the slide describe some of our worries about the research field as well as potential clinical applications. And with that, I thank you for your attention, and I have Dr. Yedin's contact information here if you have questions for him. Thank you.
There. Okay. So my name is Margit Anne Petersen. I am associate professor at the Center for Alcohol and Drug Research in Denmark. And I have a background in anthropology and mainly work from a qualitative perspective, but also engage in digital and mixed method studies. And my work on psychedelic drug use is primarily focusing on what is in these settings called naturalistic settings, so outside of clinical work. And I would like to begin with a quote from a user of an online forum. It reads, "It's not my fault that science knows so little about our minds, but it's a pity for it and for the rest of us who suffer from its shortcomings. If I can do it myself right now, I don't want to wait for science to pull its finger out and possibly in many years be able to help me with my problems." So I find this quote interesting for several reasons. First of all, it sort of represents this impatience with science that exists in many of these psychedelic communities. And people feel that they are suffering from a lot of different things that they cannot get help with at the moment. But it also has this sort of built-in critique of science, that science cannot account for everything, especially when it comes to the more spiritual experiences and dimensions of psychedelic drug use, and sort of a skepticism of can science really be everything that we are hoping for. So there's this dual relationship where people are following all the ongoing research and inspired by it, and it really shows that the psychedelic renaissance is not just going on within medical and clinical settings, but also in people's everyday lives. So much of my work has to do with uncovering the understandings and perceptions and uses of psychedelic substances and in people's everyday lives. And so what I've been doing for about 5 years now is to follow online groups and communities, also do a lot of interviews with people that I have gained access to through these online groups. And this is both users of psychedelics, facilitators, so like shamans or underground therapists. So it's a very varied group of people that I've encountered. And then I've also done participant observation, which is a very typical method within anthropology where you share time and space with the people you study. And so I've been out in the forest, in teepees, in people's homes, in different places where there's retreats, ceremonies, integrations, sharing circles, and so on. And the use of psychedelics is also very varied. So it's both microdosing that people do in their everyday lives, sort of at home by themselves, and then it's sort of these retreats, ceremonies, nature walks, and therapy sessions. Yeah. So basically, it has all been about trying to get as diverse an impression and understanding of why do people use psychedelics, what are their hopes and beliefs, and where do these hopes and beliefs come from? What can we understand from that? Some of it also has to do with understanding the effects and changes that people experience from psychedelic drug use, and finally also to relate it to contemporary society, more specifically Danish society. And I work from a theoretical framework that consists of several different perspectives. The concept of functional drug use has to do with trying to understand the underlying purposes, and it has been used to sort of differentiate from what is understood as recreational drug use, where the focus is more on having fun or pleasure. Then with functional drug use, it has a different purpose, some function in people's lives. Then the British sociologist Nicholas Rose has theorized the use of medical technologies, not just to cure disease, but also to control processes of the mind and the body. And he has called this the technologies of optimization, and it focuses sort of on overcoming, or process of overcoming human limitations, and is often linked to studies of neoliberal values where people try to become more successful, more efficient, productive, or in other ways better. And underlying much of this work is sort of the notion of technologies of the self from Foucault's work, and it sort of has to do with the active process of trying to transform or shape or create the self. He has this concept called aesthetics of existence, which sort of alludes to the self as a piece of art that can be shaped or molded through creative and experimental processes. And this is actually very much in contrast to some of his earlier work, which had much more focus on the disciplining forces and less space for the individual to create. And actually, as a side note, in 2021, a book came out called The Last Man Takes LSD, and it actually is a sort of theory of why Foucault's theory shifted so much, and it's believed to be connected to an LSD trip that he took in 1975 in California, where he sort of opened his mind to other ways of thinking about the self. Finally, there's a book by Kogelberg that is called Human Being at Risk, and it is sort of an attempt to think about human enhancement and transhumanism, posthumanism, from a philosophical point of view that has to do with thinking about existential vulnerability. So it's sort of a way of turning the coin in terms of enhancement and saying, what is enhancement actually about? And it's about managing human vulnerability. And I'll get back to some of these theoretical points at the end. For now, I want to go into three main themes that emerge when I look across all the different types of data that I have over the years. And these are three themes that I'll just briefly explain and give a few examples of through quotes. And they are the notions of exploring the self, enhancing the self, and treating the self. And to begin with, exploring the self has to do with this sort of curiosity and openness of, could life be different? Could I have a different sense of self, or could I somehow experience new things? These are some of the questions that people ask themselves in relation to psychedelics, and this is some of what they explain they use psychedelics for. Sometimes it has to do with being stuck in life or being bored, and trying to sort of spark something new. And sometimes it's related to processes of self-development, but it's not in a therapeutic sense, as we'll see. Sometimes there's also a shift between types of use. So someone might start with a recreational use of psychedelics and then experience something that makes them understand it more as medicine or as a spiritual journey. I'll give a few examples. I see psychedelic substances as a key that gives you access to what there is. It opens up to the consciousness there is. It all started 5 years ago when I got a divorce and I began to get interested in these, what I now see as medicines. I started my journey curious about where it would bring me, and I think it is all about coming home to yourself. So here's an example of someone who kind of shifted his thought about what psychedelics are, and he's actually become an underground therapist and helps other people achieve clarity, acceptance, and deal with difficult things. Another example is I have never had a youth with drugs or anything like that. So it's actually not until I got settled, finished my education, and got a farm with my partner, and then it gradually started to show up here and there. I could feel this curiosity inside. And when I think back, I think it started with some film or TV show where they drank ayahuasca, and I didn't know what it was, but thought it sounded interesting. Slowly, I found my way to ayahuasca and mushrooms. So again, this sense that nothing was really wrong in her life, but she had this drive to explore new dimensions of herself or her everyday life. The next theme, enhancing the self, has a much more explicit focus on improvement of specific things. This could be students, it could be people in working life, and it's also often about family relations. It's a much more instrumental relationship to psychedelics, where there's an expectation and a belief that using psychedelics will generate certain results and effects. And these are often connected to creativity, productivity, increase in focus, getting new ideas, and also feelings or senses of being more present, acceptant, and patient. And many of these we've also seen in studies, other kinds of studies that show this. So it's sort of it's a common theme that shows up. It's often microdosing, but it's also MDMA and other substances, And I include MDMA here, even though it's often not included, but it's sort of used in similar ways. And so I know it's a different type of drug, but I still include it here. So the first quote is from a couple that uses MDMA every 3 months as an almost prevention effort in their relationship. In a way, it's almost like couples therapy without the need for therapy. We don't really need to talk about anything. We do need to spend time together without any interruptions, just sit there and stare into each other's eyes and think that that's the most amazing thing. It adds something to the good thing we have going on. So they get their kids taken care of, and they have this 24-hour MDMA experience together every 3 months. And it was not just about staring into each other's eyes. It had a lot to do with sexual intimacy and other aspects of their relationship, but it still had this sort of enhancing effect on their everyday life. And another example, my sense of self has grown so much every time I've been to a retreat, both my self-development and my self-understanding. it only gets better from drinking ayahuasca. I feel like I become a person. And the better I feel in relation to myself, the better I feel in relation to others. So again, this sense of becoming a better version of herself, and which is quite common. The last category, treating the self, has to do with viewing psychedelics as a kind of medicine or treatment. And as you can see, there's a very long list of things that people use psychedelics for. And it's a very, again, a very varied group of people that I've been in contact with, because some people actually have a diagnosis and are medicated and are trying to sort of get a better effect from the medicine by taking less medicine and then complementing it with psychedelics. Some people stop their medicine and then use psychedelics instead, and other people are sort of more self-diagnosed and are not really so specific about what the diagnosis is, but they definitely feel that something is wrong. And then there's a big variety in the relationship to the health care system and health authorities in general. So some people have tried conventional treatment and they are not getting the effects that they hoped or wanted. And others have a sort of a general mistrust in the healthcare system and have decided to go alternative ways. And then there are some who also kind of use both kinds of methods. So I'll read a few quotes again. I lost a couple of important games, and at the time I was in a troubled relationship, so I started to feel stress and anxiety. I was not myself. I couldn't really do the things I normally could. My dad has been in antidepressant treatment for 20 years, and I've seen what that did to him. I just knew that was not my way. So I thought, what can I do for myself? And then, almost magically, I met someone who knew someone who offered MDMA-assisted therapy, and it made a huge change in my life. So here, he saw his own father and decided that this was really not for him to go through antidepressant treatment. And actually, it's especially antidepressant treatment that people within the psychedelic communities are very critical of. Another example, this is then from a facilitator who says, there's this guy who came to me for help. He was deeply alcoholic and also used amphetamine daily for many years. I wasn't really sure it was safe to include him in my mushroom walks, but he was desperate and I didn't think he could get any worse. The mushroom session changed his life. He looks totally different now. He has got his life together and he hasn't touched any substances since, except he comes to my walk every 3 months, and he still does. So, and actually, while a lot of people explicitly look for psychedelics to sort of get out of another substance use, many people also just use psychedelics for other reasons, and then they experience it as an unintentional consequence that they don't no longer have a desire to drink or use other drugs. So it's both ways, but a lot of people experience that it sort of takes away their desire to use any substances. So just sort of coming to an end, if we look at psychedelic drug use as a sort of technology of vulnerability, a way to sort of understand all these diverse uses and experiences connected to psychedelic drug use, it also kind of shows that maybe the concepts of treatment and enhancement, which in the literature is often portrayed as opposites, maybe they're not so different. Maybe they are on a continuum rather than being two very different things. And often it's in ethical debates about who should get treatment and who's not well, who is taking something just to boost themselves, and who is actually in need of treatment. And these sort of discussions take place in a lot of bioethics settings. But here, all these settings that I have pointed to today, they are all already existing outside of the healthcare and legal system. They're all sort of underground, it's secret, hidden, illegal, and not widely accepted. So maybe it's more sort of useful to think of them as insights into what is it that people do when they feel vulnerable. What kinds of vulnerabilities are we seeing in today's Danish, but probably broader than Danish society? And can we maybe understand it as also getting a glimpse of the limitations of the Danish welfare system, where we have a strong welfare system where it's sort of widely believed that at least the basic needs should be able to be taken care of. But here we're seeing that people think that the key to success and to well-being is more of an individual responsibility and endeavor. And I want to end with a quote about this. So, the advantage of using psychedelics is that you do it by yourself or maybe with good friends. Therapy might be more socially acceptable, but then again, not really, because it's not easy to say to anyone that you've been seeing a psychologist. So psychedelics are not only thought of or understood as something that can help with human vulnerability, it's also a way to not show to the welfare system and to the public that there are any vulnerabilities. So the vulnerability is not just about being human, it's also about showing it. And so there's this double sort of understanding of what psychedelics are doing. Finally, my last slide, just connecting this to the wider study, I have a 3-year project going on where we're looking at the role of the internet for psychedelic drug use and understandings and perceptions and online discourses, and looking at what are the social learning processes of psychedelics through all of the stuff that's going on the internet. And what we also are trying to do is trying to help within the treatment system, because as it is right now, when someone comes to treatment with a problematic experience from psychedelics, the people who work in the municipalities who are taking care of this treatment, they are not so sure how to help these people. And we're seeing an increase in young people, very young, like 16, 17, coming in with these problematic experiences, and no one is really sure how to help them. So part of this project and this focus in uncovering what it is people are doing with psychedelics is also to be able to generate some specific treatment guides within the Danish system that is drawing on the alternative therapies and underground therapists, as well as people's experiences. Thank you.
Thank you. Yeah, thanks for the organizers to allow 2 psychedelic sessions, one last night with a great panel discussion, but in that there was not that much time for people to be involved in conversation. So we hope that in this session we will have a little bit more time for that. And also thanks for Johannes to put this one today together. So I'm David Erritzoe, and you might recognize the accent because it's kind of the same as Margit's, because although I represent Imperial College and have worked over there for 14 years in London, I'm also Danish like Margit, so we apologize for 2 times Danish accents in a row. So I'm a psychiatrist. I'm actually same as these 2 colleagues here, associate professor, but at Imperial is called clinical senior lecturer, is the same thing. And so psychiatrist and involved in a range of psychedelic studies and also other kind of pharmacological research with neuroscience at Imperial. I'm having an advisory role for some of the new companies in this psychedelic space, and we collaborate with a few other companies that we need to do that because that's the only way to get the compounds that we can use in our clinical trials. So we have relationships in that way, that they are still independent investigator-led studies where we typically give safety data back, but it's under the control of the academic institutions and the researchers, the studies that I'll be showing data from. So briefly, and I will go a bit quicker through it because Johannes already went through some of it. So psychedelics are typically sort of categorized in phenethylamines and tryptamines. The classic serotonergic psychedelics, they are the four that I have boxed here. And one thing that wasn't mentioned is a little bit relevant for the current development and the focus in the field, and that has to do with how long the psychedelic experience actually is. So mescaline, which is not that studied in this modern era, in this renaissance of psychedelics, and one of the reasons is that it's really quite long-lasting, so it's not super practical to do full-dose trials because you might have people to stay overnight and so on, and the therapists need to be at work for a long, long time. A bit same thing with LSD, quite tested out in microdosing. In some studies, they are using the full dose, but again, very long days, very long sessions, so a bit of an expensive model and not super practical. So psilocybin is the one in focus, the one Johannes was talking about, and also the one we have been doing most work with. The experience is 4 or 5 hour long. It's the active compound, the metabolite is psilocin, as was explained, and was also explained is that they are these classic psychedelics. They are similar in structure to serotonin itself, which also informs some of the pharmacology, how it works specifically in the brain. I have sort of grayed out a bit the atypical, which is one way of referring to them, atypical psychedelics. The reason why we might still want to call them psychedelics is that they do induce some kind of altered state of consciousness, such as the psychedelic. The nature, the phenomenology is a bit different. The pharmacology is quite different. So therefore, they could be categorized as atypical psychedelics. But they're also very interesting, and they're also being in focus these years. One of them is MDMA, which is, as people might know, quite advanced now, finished phase 3. So basically, actually to the end of the clinical testing phase, and now in the phase of submitting the files to the FDA in the US. That's MAPS, the organization who have been conducting these phase 2 and 3 trials for PTSD with MDMA. So that is actually going to be the first one being approved. And when I say the first one, that's if we do not count ketamine, because ketamine is a medicine. It comes from medicine, it comes from anesthesiology. It has been repurposed in an enantiomer form, so just the S version of ketamine by Janssen. They developed a nasal spray formulation of the S enantiomer, ketamine or Spravato, a sort of nasal spray formulation. But so they have tested that, which is great for the understanding of ketamine, because people are now racemically using the good old cheaper ketamine, IM and IV, and also oral administration for the indication of treatment-resistant depression in particular. So that Spravato is licensed for treatment-resistant depression. It works through the glutamate system. It's an NMDA blocker. MDMA works more presynaptically in the serotonin system than the psychedelics. And then the last drug here among these atypicals that I want to point out is ibogaine. Very fascinating compound, very, very long lasting, requires much more safety monitoring, so it's much more complicated to use. There's some cardiac effects that makes it required to be very monitored. So that's much more tricky, but there are work ongoing, not by us. We might do some imaging work, hopefully, in the near future on that compound as well. It's very, very strange and different pharmacology from the other drugs, and not fully understand, actually. Johannes already mentioned a lot of these complicated that in my bad Danish background probably can't even pronounce. No, I should be able to after having been working in this field for a while, but I don't need to now that Johannes mentioned them. The term psychedelic comes from Greek, refers to mind or soul revealing or manifesting. And as you can see, without me listing them, every term here in this cloud, I think the take home for people who are not at all used to work or think about or know much about psychedelics is you can see that the phenomenology, the psychological experiences are deeply, deeply different from opiate, from stimulants, from sedative drugs, from alcohol, and so on. Very, very different, and much more, I would say, sort of elevated and interesting sort of abstract psychological phenomenon in that spiritual, mystical type direction. And in particular, those to the left in the cloud are the ones referred to as mystical type or sometimes psychological peak experience, coming back from William James. And scales have been created, some of them from the 60s, altered state of consciousness scales, and later on by Johns Hopkins mystical experience questionnaire and so on, to tap in with questionnaires validated to assess these experiences. And that is what's being used in a lot of these studies to try and understand what actually happens and what is it people are experiencing. In addition to that, there's a lot of important work, including by people like Margit, doing more qualitative, free narrative work of what people are experiencing. We're also doing that in trials as well. So in terms of the safety, we have done some PET imaging work looking more in the real naturalistic world. Recreational use of both MDMA and psychedelics doesn't look worrying. What we see with PET markers in the serotonin system, particularly not for the psychedelics, MDMA in high recreational use, a bit more tricky in terms of the impact on the serotonin system, but that's not the focus of this talk. It's more about the classic psychedelics that I'm talking about. They do not form dependent behavior, and they have this wide safety window, so you can take very high doses without having any significant impact on your cardiovascular and respiratory systems. So that's reassuring for the classic psychedelics. This is for classic serotonergic psychedelics. They are novel, more synthetic psychedelics, for instance, drugs in the NBOM group that are more toxic. So it doesn't mean all psychedelics. I speak here about the classic serotonergic psychedelics. And that is shown also as from Professor Nutt, who is sort of the head of our center and my mentor. This work 10 years ago about classifying, trying to compare apple and bananas in terms of toxicity, and that has been replicated by several others in other centers since then, this attempt to compare harm to individuals and harm to others from these compounds. And you can see that alcohol comes out on top. It drops down to number 4 after crystal meth, crack cocaine, and heroin. If you just think about the harm to the individual, then it drops down to number 4. But down in the other end, in the right-hand side, that's where we have the psychedelics and also MDMA. In terms of where they are tricky, the classic psychedelics, that's more the psychological, the experience element of it, that they can be quite overwhelming, and that in a way is almost informed by these fantastic things up here. They can bring up material, they can be overwhelming, they can be anxiety-provoking during the experience, but typically people have this sort of breakthrough during these sessions with these drugs, and that's why in a way they come out with something important and useful in therapy that overall is quite positive, but it can be very challenging during the experience. And if you do it in the wrong setting, unprepared, maybe if you're very young, some people can be quite traumatized by the experiences, but that's all out in the real world. We know about that people can be quite traumatized by these psychedelic experiences. So that's where the main tricky thing sits. In terms of nausea, headache, a lot of them produce some of that while the drug is in the body, in particular ayahuasca, very nausea-provoking. People then have integrated the vomiting into the rituals of ayahuasca, smart, and as a cleansing. So then so I've been attacked for having it as a side effect. I'm like, I'm a medic, that's a side effect, but they're like, it's part of the ritual. Absolutely fair enough. It, of course, can be used in that way, and that's fine, but I still call it a side effect. And then, again, psychologically, something that I brought up a bit yesterday in the panel, false hidden memory, that sometimes, not often, but it can happen, that very difficult early trauma experience come up. Is that real trauma? Is it hidden memory? Is it a symbolic representation, like a dream-like thing? What is it? That can be extremely delicate territory. So I think it's worth actually pointing out, and also we will start using that part of the consent to explain that to people going through these experiences before they go through it, that there can sometimes, rarely happen something like that, and it might be like dreamlike, but it can be hard to figure out whether it's real or not. In terms of its pharmacology, zooming in on the serotonin synapse, psychedelics, they stimulate 2A receptor, one of the 14 receptors in the serotonin system. It was already mentioned, it's a postsynaptic receptor. It's very abundant in the cortex, and it's very protective, preserved through evolution. You have on the presynaptic side, the reuptake, that's where SSRIs work, that's where MDMA work, So that's on the other side. That's on the production side of things. So psychedelics don't really interfere with the production. That's also why you don't enter a depleted serotonergic state with maybe low mood. That does happen sometimes recreationally with MDMA, not in therapy because it's given early in the day and safe and clean and so on. So it doesn't seem to happen with MDMA in therapy, but recreationally that can happen. That's because it can deplete, if you use it a lot recreationally, the serotonin system. But the psychedelics don't, because they work on this side of the synapse. We can see that the more potent they stimulate the 2A receptor, the classic psychedelics, the more potent they are as psychedelics. And if we selectively block the 2A receptor, then you take away the psychedelic effect. We can also, with PET imaging, measure occupancy on the 2A receptor and see that the more they occupy the 2A receptor with PET imaging, the more effect of the drug you are experiencing. It also correlates with the blood levels, so all fits together. And additional information from this kind of work for this study is that down in the, I don't know if I can, I don't think I can point. Anyway, down in the lower end on the graph, you see that doses that are used for psychedelic microdosing, which is typically a 10th to a 20th of a full dose, down in that range, actually there is significant occupancy, 30-40% of receptor occupancy. So that, in a way, signifies there could be pharmacological reasons why psychedelic microdosing might work. We have shown that it doesn't look like it works beyond placebo. I'm not talking about it. We can discuss it if there's time, if people are interested in microdosing. In the full dose work, there's a lot happening. There's a lot of investments into the space, a lot of new companies stepping in. I mentioned MAPS, but there are other companies. That MAPS is the one doing the MDMA work. There are a lot of work done in different kinds of addictions, depression in particular, both with psilocybin and with DMT, for instance. This experience that's really short when DMT is given in its pure form is not orally active, so it has to be IM or inhaled or IV. We're using it IV in our lab. And you can see, so there's a lot of listed trials ongoing, and there are a lot of them in phase 2, some of them moving to phase 3, and MDMA has already been completed in phase 3. If we step back in time more than 10 years to some of our early work, we started doing some imaging work. It's the first imaging, I think, ever with psychedelics. No, that's not true. There was some other imaging work that had been done. But we were, in a way, trying to understand the neural correlates of these effects that these drugs induce, and we were building that into the existing evidence from depression work in order to find out whether we could move it towards a trial in depression. And some of the things that are known from imaging work in depression is that there's sort of increased activity in medial prefrontal regions, and there in rumination, which is a sort of a core thing in depression, with sort of vicious circle, rigid thinking, trapped in thinking, thought loops. There's a hyperconnectivity with fMRI between dorsal cingulate and these anterior regions sitting within the default mode network. So some of what we saw early on in healthy people with psilocybin was the opposite. So in the opposite direction of some of the depression literature. So that in a way reassured us, together with the safety data and the historical data and meta reviews of the early trials in the 1950s, 60s, showing that they had effects for depression. All that together with this imaging data made us move towards depression. So we did a first depression trial in 20 patients with treatment-resistant severe depression, 2 of them moderate depression, all treatment-resistant, 18 of them severe. We have had MRI imaging in the trial that was sitting the day after the full dose with psilocybin, and obviously also at baseline. That was published a few years back now, and overall what we saw was significant and rapid drop in the depression scores in these patients. It was an open label feasibility study, so there was no control condition in this study, but it obviously made a bit of a stir and a lot of optimism, and in a way I think encouraged some of these people to set up companies and explore it further. And we also saw, exactly like Johannes was showing, that there was a relationship between the nature of the psychedelic experience and the treatment outcomes. So it's a correlational thing. So you can't really speak about causality with that kind of data, but it's really interesting and points towards a different paradigm from what we're used to in pharmacology, that there's something about the actual experience in this treatment model, and also that a single intervention have such long-lasting effects, up to 6 months average in this trial. So those two things together that's where the paradigm really differs from what we're used to, and that's what I have basically written there as well. Okay, so that's not the only trial. A lot have been done, a lot of pilot work, healthy people increased in well-being, validated scales related to well-being, OCD symptoms in a small pilot trial. We are now doing another OCD trial at Imperial. End-of-life distress decreases, anxiety decreases, and addiction as you saw before, and depression, as we have been doing quite a lot of work with at Imperial, but also others, including Johns Hopkins and other places. And what we see across these trials is not just in our trial, but there seem to be sustained effects after 1 or 2 sessions with a psychedelic, which is interesting, obviously, and have induced all this optimism into the space. We then did another study as follow-up on our non-controlled little proof of concept one, and that was a bigger trial where we had compared it with escitalopram SSRI that performs very well and is very selective for the serotonin system. So we thought that would be a good, interesting one to compare psilocybin to. Obviously, it's difficult because psilocybin single session SSRIs every day. So I'll show in the next slide how we decided. I just want to mention, when we do it, we create a pleasant, supportive setting with dim light and different sort of elements of nature, or something that looks like nature, and guides in the room. We prepare people well. We screen out people with a history of psychosis and so on in these trials in general. And that's just to say that we have recently created a new research clinic at St. Charles Hospital in London. So now we are in the NHS, so in the British health system, and have a research clinic there that we have purposely built for this kind of research. This is the trial, so it randomized to either 6 weeks of escitalopram daily, and then 2 sort of fake sessions with a very low psilocybin dose, 3 weeks between, or in the other arm, placebo capsules instead of the escitalopram, and then 2 sessions with psilocybin full dose, 25 milligram. And then we had MRI as well, baseline, and in this case at the 6-week time point, which was then 3 weeks after the second dose of psilocybin. The data are here, so you can see that to the right, you can see everything that's green and set to the left. That's because it's statistically significantly favoring psilocybin over escitalopram in the trial. So most scales, including 3 out of the 4 depression measures, did, but our predefined primary outcome, QIT, which is a self-rated depression, did not significantly statistically differ between the conditions. So that's why overall the trial is presented in New England Journal as a little bit less encouraging than when you actually look at all the data from the trial. We saw quick onset of effects, and we also saw, for instance, as one example is that there was complete separation statistically for improvements in well-being with psilocybin. Also, response and remission rates significantly and remarkably higher with psilocybin in this trial. When we look at the follow-up data, 6 months, both are better than they were at the beginning. So a sustained effect, again, seen in this trial, but also in the escitalopram arm after they have stopped treatment, that we can, maybe if people are interested, we can discuss it more. It's difficult to understand, but of course an important element to the trial. Another interesting and important thing to mention is that, and that's because that's something we need to find out what to do about, is do we need to take people off SSRIs before we come in with a psychedelic treatment? That we did in this trial because there's no safety data to keep them on and then come in with a psychedelic on top. But when we separated post hoc, look back at the data, we can see that the people who had to be discontinued because they were on an SSRI or SNRI, either, if they had to be discontinued, then they did not respond as well to psilocybin, and they responded really well to be put back on an SSRI in the trial in that arm. So it massively separated in the people who were just not on anything and didn't have to be weaned off and could just go directly into the trial and be treated with either drug. There it separated massively. So that's an interesting observation from that trial. In terms of this thing about can people stay on or not, so there are work from Basel from Matthias Lichtig's group, where they had tried in healthy people just for 2 weeks SSRI or placebo, and then gave psilocybin, and they can see that there it looks fine. The plasma levels are fine. The safety is fine. They get the same kind of subjective experience. So that data support that it might be okay to be on an SSRI when you give psilocybin. And Compass Pathway also did, I think, 19 people or something like that in their big trial where they kept people on SSRI and also saw fine results and no difference from the people who were weaned off. So it's conflicting evidence at the moment. And just to mention, we have looked in big surveys. We do a lot of also surveys. And one of those, we have looked in people who exactly stayed on SSRIs when they, out in the real world, undertook a psychedelic experience. And what we can see is that it seemed to reduce the actual subjective experience, which is also massively supported by online reports from people. And we see that in our survey when we look at the data as well. So conflicting evidence at the moment about whether you reduce or impact, inhibit the effect of psilocybin if people are on SSRI. Some of the mechanisms psychologically, what we saw with psilocybin was a decrease in rumination and also a reduction in thought suppression, so the two defense mechanisms psychologically that are active in most people with depression, and that we did not at all, we didn't see, as you can see, that we didn't see that with escitalopram in this trial. In terms of the brain, as I mentioned, we did MRI. And what we then did, we had two separate trials. We had the open label in 20, and then we had where we had people randomized to SSRI versus psilocybin. So when we look at the data from those two trials and then applied a global connectivity MRI analysis approach called modularity analysis, what we found was that modularity is decreased in the psilocybin, after psilocybin, in such a depression trial, actually in two different depression trials. It's not in escitalopram. And we can also see that this decrease in modularity, which is basically a measure of increased global functional connectivity, we can see that relates to the outcome and is not related at all in escitalopram. So could that be a mechanistic difference? It needs to be explored further, but quite an interesting observation. And also we also see differences in emotional phases with a task-based fMRI, where you see a blunting with SSRI, but not with psilocybin. So also an interesting brain mechanistic different observations. Just to complete the depression story, the big trial from Compass in 233, so much bigger trial, multi-center trial, has recently been completed, supportive again of psilocybin in the 25 milligram full dose being and having antidepressant effect above the placebo doses or medium dose 10 milligram that they used for comparison. And then a little sidestep just to mention other work we are doing with depression. So we're also using psychedelics in another way. We have a psychedelic tracer, radio tracer for PET, which is again a serotonin 2A agonist. We have applied that in depression. So first we developed a method where we can pick up release of serotonin in healthy people if we give amphetamine combined with this psychedelic tracer, which has been tried for decades in the serotonin system to measure these things, and it hasn't really worked. But that worked with this combination of this psychedelic tracer with amphetamine as a drug challenge. Then we applied that in depression, and that recently came out, and it's a bit of a stir at the moment because of Moncrief, and that some of you might have seen that some months back, where challenging the relationship between serotonin and depression, the evidence for that. That is being challenged a bit back at the moment, and this, in a way, this new data, which is the first more direct study ever to actually measure serotonin a bit more directly in the living human brain, in a way supports that there might be something about serotonin deficiency in depression. So you can see that's other work where we are doing that is not directly related to serotonin and depression, and is using a psychedelic tracer. Otherwise, it's not really that psychedelic, this study, but thought it was meaningful to mention. This has already been shown by Johannes, most of it. He didn't show this one. When you look back, though, when you look back at the data from the 1950s and 60s, most of that work back then was done with LSD for alcohol, a single drug, single indication. That was the most commonly studied. And when you look at that data, short and medium term therapeutic effects were significant and good for LSD therapy for alcohol addiction. So that's part of the reason why this addiction work is happening at the moment that Johannes already spoke about. And Bill Wilson, as mentioned, one of the founders, he actually became abstinent after LSD therapy himself. Already shown the new Bogenschutz study, interesting big study, relatively big psilocybin therapy for alcohol showing good effects. This one I don't think was mentioned. This is ketamine-assisted therapy done in the UK by Celia Morgan's team, also showing solid effects on drinking behavior, so using ketamine and not a classic psychedelic, but similar good, strong effects for addiction. And here's some quotes that I think I'll skip. And another study, which was MDMA-assisted therapy instead for alcohol, small pilot trial done in Bristol by a colleague who's associated with us at Imperial, Ben Sessa, and also showed good early pilot data in a trial with MDMA-assisted therapy for alcohol addiction. And this was already mentioned. This is the smoking cessation work, mainly led by Matt Johnson at Johns Hopkins, and that is now being expanded to several centers, as explained, also with NIDA funding, and showing really promising effect in smoking cessation with psilocybin intervention. Opiate addiction, Johannes mentioned that Wisconsin and Johns Hopkins are doing that now, and that is true. And so are we at Imperial, setting it up in a different design than they are. So we supplement each other and work together. But there actually was an opiate study done with LSD therapy in the early 70s, and the results were actually pretty good. And here are some of the quotes. Now I don't have heroin, I'll just read the first one. Heroin has a numbing-like effect on you. It tends to relax you and somewhat takes you out and away from your surroundings and yourself. LSD makes you more aware of yourself and puts you right into whatever has been troubling you. So a quote about a bit of the difference between opiates and a psychedelic, here in a psychedelic treatment study from the early 70s. And so that, again, is part of the reason why we're bringing it back. Metzner had some interesting thoughts about altered state and expanded state of consciousness. He sees addiction as a narrowed state of consciousness, psychedelics as an expanded state, and then some of the dissociatives like ketamine, like a sort of push to the side dissociative state, which is interesting and potentially testable. So we are setting up cue reactivity work that we are testing in gambling, MRI with video cues, and putting in social connectedness, nature relatedness, nature cues, in order to test some of the things that we see in psychedelic work with scales, so questionnaires, to actually test some of that in the brain, whether we can see this sort of broadening that Metzner also referred to. And so far, we can see that people, which is aligned with previous cue reactivity work done in addiction here in gambling from our lab, this is just N of 1, because we don't have the full data set yet. So the reason why I dare to speak about N of 1, which is deeply unscientific, is that there was a documentary where it was in, so I feel I can show that, that we see that for this person with severe gambling addiction didn't have brain reward circuit response to food, nature, and social connected cues, but massively to gambling-related cues. And we would like to apply that in addiction work with psychedelic therapy to see whether we can rebroaden this hijacked, narrowed reward spectrum. A bit about possible mechanisms. Already explained that plasticity in preclinical work is a thing with psychedelics and MDMA. Yeah, I'll stop in a moment. And we can also see global increase in functional connectivity that I already mentioned, increase in entropy or brain complexity are some of the things, and we are going to measure in humans with EEG paradigms, plasticity, and also PET work with plasticity. So we are doing that at the moment. Also more psychologically, disconnect turning to connectedness, avoidance turning to acceptance, and reduction of negative cognitive biases. And I already mentioned the other ones, increase in trade openness. And that I will skip this Robin Carhart's Rebus model, very interesting, but I think we can save it for discussion. And then this is my final slide, just listing some of the work we are doing in our team at Imperial. We are doing, as I mentioned, OCD, psilocybin work, chronic pain, anorexia nervosa and setting up opiate addiction study with psilocybin as well, and doing a lot of mechanistic MRI, EEG, and PET work in order to try and understand how these work and what are the therapeutic mechanisms. So thanks a lot for your attention.
All right. So as I said, now I'm quickly going to put on my discussant hat, and then we can go into the Q&A from the audience. The first point I wanted to make was on potential mechanisms of action. We talked a bunch about the neuroplasticity, alterations of brain network connectivity, the potential mechanisms related to emotional processing and alterations of reward and stress processing, and increased social connectedness, which I think is, and the subjective experience of personal meaning and experiences, to me immediately suggests that there might be certain psychotherapeutic approaches that are potentially more or less appropriate to sort of accompany that psychedelic experience. Little has been done, if any, research to systematically investigate the role of psychotherapy in these combined treatments. That includes the type and dose of treatment, including group versus individual treatments. Third wave CBT approaches, including in particular acceptance and commitment therapy, seem well aligned with some of these hypothesized mechanisms around acceptance of negative stimuli, around mindfulness and being present in the moment. So I think that the field is moving towards being ripe of systematically also investigating the role of psychotherapy in these treatments. As far as the treatments are concerned, and I already mentioned this, sort of we're looking at aggregate treatments, right? That are even if you're just looking at the psychotherapy usually contains multiple different smaller interventions that are part of a package. And a randomized trial tells you little about the active ingredients of an intervention. So there are potential interaction effects of treatment components that are, at this point, very much unknown. In a mobile and digital health space, we've been thinking a lot about how to disaggregate treatments into individual components and test those components. And so I think systematically testing components of these interventions are a potentially important step forward. For example, looking at the multi-phase optimization strategy by Linda Collins at NYU, or factorial designs, smart designs. Of course, the issue there is always, at this point, sample size and how to get enough participants into these studies. When we think about the public health impact, right, clinical trials have their limitations to study those impacts. There's the difficulty of true blinding for psychedelic administration. We've talked about this a lot. I think that's probably more concerning with short-term effects. With long-term effects, like the smoking cessation trial that had a 30-month follow-up, I'm less convinced that expectancy effects are, of concern when we're looking 2.5 years out and we're assessing biochemically verified smoking cessation abstinence. However, the knowledge and interest among the general population is unknown, but it's also rapidly changing based on publicity. And what Margit's presentation demonstrated is that people are going to use these things in all kinds of settings, whether we like it or not. And so I think one of the take-home messages I had from her presentation, sort of at the end of her presentation, was the importance of public health awareness, of information to the general population around safe decision-making when they are deciding to use these compounds, because they most certainly will. And yet the need to investigate the real-world use and impact of these substances. And so lastly, I want to talk a little bit about equity. So where we are based in the US, we know that racial and ethnic minorities are underrepresented in psychedelic research, as in a lot of research more broadly. That's due to individual but also systemic factors. I guess an example that to the counterpoint, one of the studies that David actually mentioned from 1973 was a study that was done on a sample with predominantly black participants in opioid use disorder treatment. But thinking more broadly, who will have access to novel and costly treatments? And even beyond that, health services are responsible for only a fraction of health outcomes, right? So we certainly cannot expect that this will be a silver bullet that will all of a sudden reduce all health disparities. And so thinking around policy topics, around decriminalization and legalization, Dr. Carl Hart at Columbia has made the point that there is a risk of psychedelic exceptionalism, that we're treating these compounds as, the exception. They certainly have, low addictive potential, which is, and potential for treatment efficacy, which is great. At the same time, when we're thinking about the, drug laws, the war on drugs, which drug laws harm the most people and which populations experience the greatest harm? I can guarantee you in the US, it's not psychedelics drugs that impact especially minorities, right? And so when we're thinking about decriminalization and legalization, which a lot of states in the US are sort of thinking about, and Oregon and Colorado have moved in that direction, I think we also need to expand that thinking about decriminalization and legalization of other drugs as well, because those harm minority populations in the US. And those were my thoughts, and I'm happy to open it up to the audience. Thank you. Yeah.
Good afternoon. I love to listen to these presentations. There is something that intrigues me. When people are in the psychedelic therapy sessions, they have the eyes covered, they are laying down, so not moving much. They are listening to music with headphones. Is there any reason to prefer a setting in which people are very separated from the outside stimulation? Is there any reason for that, or why could not they be just seeing things, the marvelous of the world? What?
Do you want to take that, David?
Yeah, so it's a very good question. And for instance, colleagues in Copenhagen who are doing psilocybin work, they typically don't have the eye mask on, and also the music is more just out in the room and not in the headphones. The thing about having eyes open on psychedelics is that it can be slightly distracting the visual elements, and the idea has been to close a bit off and go inside and surrender into this journey, that more happens on the inside might allow for more psychological peak elements that could be a bit distracted away from it if you are interacting a lot with everything coming in through your senses. And the reason for the music is to enhance and anchor and support and even enhance the experience by building up towards the peak, whether it's in an earphone. If you are in a place, there's also practical reasons. If you're in a place where there's quite a lot of noise, then it has a big advantage that you can shut out something that distracts by having people having earphones. If you're in a very quiet clinic space, then you might as well just have it out in the room. But the eye mask, it's also a little bit more difficult to see how people are doing with an eye mask on, so there could be advantages if not to. But I think it does make sense, part of the trip, to actually close the eyes.
I just wonder if some people would benefit to be more open to the world, while others would benefit more for this more traditional setting.
We do allow it, I think, in all trials. If people feel like being, but we do typically encourage to try to go back in and surrender into the experience. But if people want to dance a bit around, they can. And they sometimes do move around during the session. That's fine. It's not that it's not okay for them to do that. They can do that. And some people feel like doing that, and they do that a bit.
Okay, thanks.
I didn't keep track of who was next.
Thank you for the presentations. Very interesting to see the same topic from different approaches, as usual, from an interdisciplinary point of view. It's a comment, a little bit of question, especially for Margit, but a little bit also for David. As a psychologist myself, I couldn't help but to see a common theme in at least 3 of your quotes from the qualitative studies. And it's about rituals. One with a couple going for the MDMA session every 3 months. It's a little bit of a ritual. the person who stopped amphetamine and I think alcohol, and now goes for the mushroom walk, a little bit of a ritual. And the student also, who sometimes uses the psychedelic alone or with friends, a little bit of a ritual too. We as clinical psychologists, we prescribe rituals all the time as well. With couples, we recommend dates or ritual communications. If they break, relationships start to crumble too. Self-care rituals, doesn't have to be a psychedelic, can be, favorite aroma, cup of tea, smell it, and relax. So I don't doubt the active chemistry that psychedelics are doing, because they, as David described very well, they are unique, extreme, like very distinct. But I wonder, Margit, you as an anthropologist, if you have also wondered like the ritualistic behavior and aspect with all this use of substances, a little bit also implanted in David's clinical context with preparing the room, bringing nature in, and so on. So have you thought, or do you have any reflections about the ritual component?
Yeah, it's a really good point, and I think it has a lot to say. I mean, a lot of obviously this whole set and setting concept, which has been developed within all of the psychedelics, is something that people are really aware of, and a lot of the psychedelic stuff is happening in ceremonies and rituals. So I think it's an important component also from a social science perspective, that it's not all about the pharmacological effects, that there are also other effects. And for a lot of people, it has to do with being part of a community or establishing new relationships, new rituals, and so on. So I mean, obviously, I look at it as a more sort of holistic situation where the ritual and the setting and the relationships related to this kind of use are equally important as part of the experience of what people are doing. I wouldn't be able to separate the different kinds of effects from settings and from the actual drugs. So for me, it's very much a part of it. And I think also with the history of some of the psychedelics, it comes from rituals and settings from, for example, the Amazon and from Mexico and other places where psychedelics have been part of indigenous cultures for a very long time.
I might add that psychedelics in a way come from something that has a ritual where actually almost no matter where it's used, some kind, the setting, the paying attention to and creating a context that's supportive and so on, which the ritual is part of, comes with the psychedelic history and culture, whereas for ketamine, that comes from medicine, that came from anesthesiology. So one thing that could be tested would be to add the ritual to ketamine, because you can give ketamine without any setting, in a very boring, very medicinal environment, which is often done. You could try and enrich that. That would be one way of seeing how much you can add to the effects by adding in a ritual onto ketamine and test that in a way. But obviously you can't really blind it. It's difficult to blind a ritual, but you could at least try and test it a bit more.
Thank you.
Hello, thank you very much for a wonderful presentation. I was very pleased to hear about these experiences of people that was taking psychedelics with recreational intent and end up having unexpected therapeutic effects. And in that same line, and taking into account the ritualistic use and communal use that you were mentioning before of psychedelics, I was wondering, what about the use of psychedelics in group settings, but in clinical Western medicalized research? Because for the future of the field to be well implemented, it's probably going to be needed some way of reducing a little bit the cost, because it's too many hours for two therapies with a single person, and that can be extremely expensive for some people. So what are your opinion on the future of the field, and do you think this might be possible, like to have group settings, maybe with some interaction among the participants, or maybe without interaction, but for sure having less time, less resources dedicated to every single patient? Thank you.
Yeah, that's a great point. I kind of remarked on that briefly in the discussion. I think it's something to be considered, not just for the actual administration sessions, but also when you were thinking about the preparation, the integration sessions, where I think that's probably the lower hurdle to get over, right? To essentially make it more cost efficient by combining some of those prep and integration sessions into group settings. I don't know, David, if you are thinking along those lines.
Yeah, I think it will be tested. It's a little bit tricky, I think, in this phase for a lot of the companies. They just need to have this duck kind of testing of does this drug have in the conventional pipeline. So Compass has done a little bit with groups in healthies. We have data where we have stepped a bit into Margit's territory in naturalistic survey-related thing by Hannes Kärtner, a PhD student with us, who has written a paper, Communitas and Psychedelics, which basically shows in that way of investigating it that there's an added effect of the community aspect of doing it in groups. So it's definitely worth and will be and should be explored. But I think it's difficult right now for the companies to integrate it into their trials. But I agree with you. It's very interesting and important to explore.
Hi there, my name is Brad Hillier. I'm a consultant forensic psychiatrist in West London NHS Trust. I had two questions, hopefully not quite related. The first is I didn't notice that there were any trials relating to methamphetamine use in psychedelics. This is something that I was wondering if there are trials.
There is in San Francisco. They're starting a trial. Josh Woolley is starting a trial with in crystal meth dependent people.
Okay, that's certainly answered my first question. The second question is, from a forensic perspective, I mean, I think people are always a little bit worried about doing new things with forensic patients because of risks of violence, obviously. I found myself thinking about some of our patients who have a complex presentation, which may include psychosis, but not necessarily. And I'm thinking more about people with complex personality disorders associated with substance use, associated with violence and offending. And I'm thinking about the hazy area between complex trauma, personality dysfunction, and violence. I'm wondering whether this is an area that people have started to consider, or whether there are any whether there's any evidence for psychedelics being part of a presumably psychological treatment program for violence.
So, for instance, a condition like a diagnosis, borderline or emotional unstable personality disorder, is, I think there's a bit a divide in the field. What people think, whether it would be useful, whether it would be very tricky. I think my take on it is, I think it will be done. I would say that if we were to do it, or I should advise, it should be done with very, very, very careful and quite specialist therapeutic package around it, because I think it might destabilize some people where some ego boundaries are already a bit uncertain, insecure and flaky, and might really destabilize some people. I'm sure it would benefit some. We have some survey data where if people report diagnosis of personality disorder, there seem to be more doing not well at all on a psychedelic than in the other group. They are overrepresented in our surveys if they self-report a diagnosis of personality disorder. So I would say it would need to be done with great caution, but I'm sure it will be tested, because it would be in a way unfair not to see if people could benefit from it. But yeah, complicated thing. Forensic, very interesting. Trauma, again, it's a long story. There is work being set up with, in addition to the MDMA work with trauma, there's also studies being undertaken with a classic psychedelic for trauma. So that speaks to that element. We don't know yet the results.
So we're over time. Maybe just a very quick question, if you have it.
I can do it.
Okay.
Just catch you later.
Sounds great. So thank you, everyone, for your attention.